So good morning and thank you for being here. We have got a session for you on cornea, and it's called Common Corneal Procedures in Clinical Practice. The emphasis is on skills which you should have to do the procedures and the knowledge as to why you do it and why things work and don't work. These are my declarations of interest, and that's what we're going to call this today, like I said, and we are going to give you quite a few of them. We've got 6 things we're going to cover in 2 hours. If we run out of time, then we might drop the last 1 or 2, but hopefully we'll cover most of these. And I'd like to introduce my co-chair, Dr. Dalia Said. She is a consultant ophthalmologist and associate professor of ophthalmology with the University of Nottingham, where I work. So she's a colleague from the same center. And we have Rashmi, who is Rashmi Deshmukh, who is a clinical research fellow in Nottingham. She was an LV Prasad Eye Institute fellow and has come to spend a year with us in Nottingham. So they will be covering a topic each. Let's start off with the first one, corneal lacerations. All of us, no matter what specialty we work in, will see patients in the emergency who've had a corneal problem, and sometimes some of us will actually cause the lacerations because of what we do during the course of other procedures. So this can be due to a sharp instrument, or it could be blunt, and it could be with an inorganic or organic material. Why is it common to know, important to know whether it is inorganic or organic material, or blunt trauma or sharp? Because the associated collateral damage can be variable, whether it's a very sharp instrument, then it may be just the cornea and not the rest of the eye. If it's a blunt trauma causing a laceration, there is a combination of a lot of damage to other structures at the back of the eye as well as the cornea. Inorganic material usually is associated with infection risk very high, fungal, whereas organic material, which is plastics or metals, tend not to. So you have to keep that in mind. And it can be penetrating or non-penetrating, and this I will show you in a minute what that means. Whether the trauma was clean trauma or was it contaminated, again, very important. The rule of thumb is that all patients with trauma, you must start prophylactic antibiotic therapy, and if there are bits of the eye, lashes, or bits of the lid or other bits of debris, then they have to be considered and cleaned and removed. So history of what, when, and how is very important. And in our situation, we always ask for tetanus immunization if there's a record. If not, if in doubt, we give them a booster for tetanus. And one of the things which you can be asked is to, patients got a large epithelial defect and a laceration, will you put anesthetic drops? Because anesthesia slows down the healing. And the answer is yes, of course, and this is particularly true in chemical trauma. There's blepharospasm sometimes, there is a lot of pain and irritation. The patient will not let you examine the eye if you don't put a lot of topical anesthesia and get rid of the pain. So you must instill anesthesia to undertake a complete and thorough examination. And then coming to the specifics of the trauma, we have to examine the entire extent of the wound. Let me just get this here. So it's very, very important to know, and if, as we'll see in some images, the wound is extending up to the limbus, then you have to explore the sclera on either side. You must know your materials. So you're going to clean this wound, you're going to examine this wound, then you're going to start to close it, which is the main title of the talk, is how do you suture these lacerations. Every needle, and there are many different kinds of needles, many different sizes, it has these components part. Every needle, it has the swage, which is this back circular part into which the thread is clamped shut. So it's an eyeless needle, as we all know. Then you have the needle body, which is usually flat, and then you have the needle point. And this can be side cutting, it can be reverse cutting, or it could be round, and you can have various designs, but what we prefer for cornea is the flat or the spatulated side cutting with a sharp point. You don't want a reverse cutting needle. You don't want a sharp edge to the back of the needle, because when you pass it through at a certain depth, it will probably go deeper and make a cut in the cornea which is vertically higher or taller than you intended. So where the needle starts to become flat, that is just beyond the swage of the needle, is where you will hold it with your needle holder. If you hold it in the round part, it will quit swiveling in your needle holder. Very important to hold it where the needle becomes flat. And this, in practical terms, your 10O monofilament nylon needle, Alcon, Ethicon, all of them make it the 10O monofilament nylon needle. And if it is double armed, then the needle that comes with the double arm is better than the one that comes with a single arm, and I'll tell you why. So, non-penetrating lacerations. Now, you get a patient like this, and what you have to do is you have to see this wound is going all the way here to the limbus. So you have to do a peritomy, expose the sclera. There will be hemorrhage, there will be edema. You will not be able to see whether the sclera is affected or not. So any wound that goes up to the limbus has to have a peritomy to explore the sclera adjacent and how far the wound has gone. Then you lift it up, and this patient was actually referred 2 days after the injury with 3 or 4 lashes in the wound. That's a no-no. You have to clean it. You can tell from the edema how long this wound has been there. It's already become hazy. And then you clean it and you put it back into place and stroke it into place. And because this is a swollen wound and not a LASIK flap, it will not stay by itself. You have to give tacking sutures. Now, these tacking sutures have no rules. You can just put them anywhere. They're very superficial sutures, but the important thing is that you have to align the extremity of the wound first. If that falls into place at the limbus, then the rest will fall into place, and it will have to be kept, like you can see over here, and then when all the sutures are removed, there is just a very faint line over there of the scar, but the rest has fallen into place. At the worst, this patient will have some irregular astigmatism, and we have to then try and treat that with a contact lens. And after you've done this, not to forget the antibiotic cover these patients must be given, and you can put a bandage contact lens on the top. These knots are buried, but if you don't want to bury them, you must have a bandage contact lens because they are going to come out very soon. Now, if you see something like this, now this is again a non-penetrating corneal laceration. Some of you may remember leaving your book on the window and it's rained and the book pages get wet, they open up. You can never push that book back normal again. In the cornea, the same happens, but it goes back to normal on its own. One important thing I'm going to draw your attention to here is this part of the wound. It's not so important in the non-penetrating wound, but the line joining one extremity of the wound to the furthest extremity away is called the hinge. Just like a door or a window has a hinge where it opens and closes, this line is the hinge, and we'll come back to that concept. You see this very nicely in retroillumination, this hinge. So when you see a wound like this, do nothing. Just give antibiotic drops. The endothelial pump will cause the edema to settle and everything will fall back into place. You don't have to give tight sutures to try and squeeze it back into place. So if it is a non-penetrating laceration like this, let it be and it will settle. As you can see, everything goes back into place quite nicely. Penetrating lacerations, completely different ball game. So here, when you look at this laceration and you've done all the other things, you've examined the eye thoroughly, etc., now you started to suture the cornea. The first thing you ascertain is the site of entry of the object into the front of the cornea, the epithelium, and the exit into the endothelium. So where it has gone. So look at the profile of the injury going through the cornea. Where it entered the epithelium, where it entered the AC through the endothelium. Having done that, and you can draw this on a piece of paper or imagine it in your mind as you're looking at the patient, then you draw this line joining the two extremities, which is the hinge. If that hinge is within your drawing, it is a self-sealing wound. You don't have to suture it. If that line is outside the area of the wound that you have drawn, like you see here, it is going to leak and you need to put sutures. Now, imagine your cataract wound where you don't put any sutures ever if it is a properly constructed wound. Any line joining one corner of the cataract wound to the other is within the area of your cataract wound. It is a self-sealing, penetrating injury of the cornea, and it will heal by itself. So that is exactly what happens if it is a traumatic laceration as well, and or iatrogenic, like I said, we produce often. Now here's an example of a torn injury, and if you look at that penetrating injury, and if you look at the trajectory of that wound from the epithelium all the way to the endothelium there, but if you draw a line from here to here, it is all, that hinge would be within the wound, and here you can see there's leaking, but all you do is nothing, or you put a bandage contact lens and put antibiotic drops, and it will heal and it will seal by itself. The only difference here is that if you have hot metal, and a hot metal goes through the cornea, it actually causes collagen shrinkage around it, and that hole is now different because the collagen has shrunk, and even though the hinge is within it, it may take a long time to seal by itself, or it may not, and there you have to then put something else, and Dr. Said will show you. But here you are the same patient, see fluorescein there, no leaking, it is self-sealed. Here another patient, you can see a triangular wound, it's leaking profusely. This hinge, which is over there, is outside the wound, and you have to put your sutures. So what are the principles of suturing? Most important is that your suture should be perpendicular to the site of application, and then the distance between two sutures should be less than the length of your suture. If the distance between two sutures is more than the length of your suture, it will leak in between over there, and you would then have to put another stitch over there. The length can vary. Usually closer to the limbus they are longer, and as you move to the center they are shorter, the sutures, but you can vary the distance between the sutures according to the length that you are using. Now this is an example of how a corneal suturing should not be done. This was one of my medical retina colleagues who was on call, and he did things. So you can see the direction of the sutures, not all are perpendicular to the wound, the size is different, the distance between them is different, and quite importantly, some of the knots are actually buried in the wound. So when you suture cornea, whether it is a graft or whether it's a laceration, never bury the knot in the wound. And the reason is that because one day you have to take that stitch out, and when you pull the knot in the wound, if it is there, that wound will break open like this. It will either go an internal dehiscence or the whole thing will rip apart. So the knot is the one that's the most difficult to pull out. Therefore, bury it in the either side of the wound, wherever you prefer, but not within the wound. So again here, as you can see, applied perpendicular, they don't have to be parallel to each other. It is just applied perpendicular to the point of application. Work your way from the attached part of the wound towards the center. So always suture from the extremities towards the center, not from the middle of the wound, which you think you're going to suture in the middle and then outwards. And the reason for that is here. If you get the middle wrong even by a fraction of a millimeter, that whole alignment will never fall in place. If you get it slightly wrong, by the time you reach the edge, there will be a fish mouth, which will constantly leak. So always start from the edge. Those points are the closest. You will get it right, or the chance are most that you will get it right. When you stitch that, then the fixed points are moved internally. Then when you put another suture next to that, they moved, and that way the whole wound falls into place. So it is good to start here, and then move your way in. Now look at the profile of the wound. If the profile of the wound is straight, then you go equidistant on the two sides with your suture from the edge of the wound, and you get the right compression force to oppose the wound without slippage. If it is an underriding and overriding edge, like here, an oblique wound, it is easy to get the wound to slip. So what you want to avoid that by the way you place your sutures. You want it to join back like this and not like this. So what you would do is, it's very important that the distance from the edge on the underriding part of the wound is further away than on the overriding, so you get the right compression to bring it together. If you look at the forces that are applied, it is also written, and probably rightly so, that if you take the internal edge, the internal part of the wound as a center, you could then probably place your sutures that around that point rather than around this point, and you can get equal compression. But this is what I follow: go further away from the underriding edge and closer to the overriding edge. Triangular wounds, the rules change. In a triangular wound like this, the axis of the suture is directed not perpendicular as you see here, but towards the base of the triangle to get the right compression. If it is a very sharp apex to the triangle, you put an overlay suture. If it is not a sharp apex, you can put a suture there. And if it is a stellate wound like this, then you can put multiple sutures, always starting from the attached part or the extremity of the laceration, working towards the center. And inside here, you can pass a running stitch through the stroma all the way and bring it out of the wound, tighten it, and then you can roll it away from the wound. And usually this one is completely buried and you don't take it out. If it is still leaking, then this thing here is to remind me to tell you that you take a piece of cyanoacrylate, or take a bit of cyanoacrylate glue or a fibrin glue, and again Dr. Syed will tell you much more about that. Now, looking at the depth of the wound, how far will you go? So if you go like that, 80% of the depth, then along and like that. Now it's very difficult to get right angles in the passage of your needle because it's a curved needle, but you go vertically straight down, turn it round, move along, and don't start directing it towards the surface right as you start. Move it along flat and then turn it up, and you will get this mattress effect. If the wound has a disparity in the host and bed, this we see often in corneal grafts, not really a laceration, but it's a very important point to mention here. Then always align the wound at the surface, not internally. So any disparity in the wound, you transpose that to the back of the cornea, not the front of the cornea, and then you will pass deep suture over here, but you will bring it out shallow, comparatively speaking, over there, so that that wound will align like that. If you put that suture right down here, it will pull this part of the tissue of the cornea down, and you get a step over there. That's not what you want, because that will then cause a lot of epithelial healing problems and also change the anterior curvature, which is quite important in refraction. If you go very deep, and we have now been able to show that if you go through the pre-Descemet's layer or through the Descemet's membrane, you get this crow's feet type of striae. If you keep your suture anterior to Descemet's membrane, so go 80% depth like I said, you will not get these striae, and sometimes these can be very annoying if they've gone right into the center of the pupil. If you have tissue loss, then there's a different problem. Or if you have an iris prolapse, then what do? The classic teaching is excise any iris that is prolapsed, because it has a risk of infection if you push it back in. But what I will tell you to do is clean it, and if it is not a contaminated wound, if it was a sharp metal injury and the patients come to you within a day or even 48 hours, I would be looking at, more importantly, the viability of that rather than the risk of infection. So if you touch it and it's bleeding, that means it's still viable. You can push it back in the eye. If it is not bleeding and it's necrotic, then there's no point putting, because it's only going to cause inflammation. You use a lot of Helon if you want to recreate the anterior chamber, and then so if it's a collapsed anterior chamber and the cornea is not in its normal curvature, you pass your sutures, then fill with BSS before you tie it, because then you will get the apposition in the right shape. Otherwise, if it's flat, and you'll get a very flat shape. So get the shape right when you're finally tying the knot. And these are some examples of sutures. When you take the sutures out, you have a situation like this, a very scarred looking cornea. An important point which you may or may not know is that when you have very irregular cornea or very high refractive errors, the pinhole does not give you the true visual potential. you have to put a rigid gas permeable lens on the eye of any kind of base curve. You want it to sit on the eye just for 2 minutes or less, and then give the pinhole. So RGP pinhole vision for corneal surgery is a very, very important, very simple but very important concept. You neutralize the curvature of the cornea or the irregularity of the cornea with the rigid lens, then give a pinhole, you get very good improvement of vision. You know this patient has good potential. So here are some other examples of suturing. They don't always come classic triangles. So there's a triangle with a spur, and you suture that. This is a very, very badly traumatized eye, and had to suture it and then put a keratoprosthesis to get the VR surgeons to sort out the internal of the eye and the retina and then the cornea. Here is one with a bow and arrow injury. You can see there's another direction spur. So you treat what you can according to the principles and then treat the side arms separately. But you can get a reasonably good outcome at the end. And here again, before rushing to a cornea transplant, I would put a contact lens. And if the contact lens improves the vision, then that is the treatment for this patient. And like I was saying, if there's tissue loss, then you can do this a patch graft. And here are some examples of a patch graft. So you will sometimes put a cornea over the sclera and the cornea. And then later on, you come and repair that with a full thickness graft to get sight back to the patient. So basically, the trephinition over the sclera is partial thickness, through the cornea is full thickness, that the cornea then with the endothelium intact, the donor button 4 millimeters or 5 millimeters, then rests in that like you see over here. So this is your scleral side of the trephination, this is the corneal side of the trephination, and you bring the whole cornea and you put it in like that. And because the sclera is thicker, usually it will fit in and then you stitch it into place. So take home messages: follow the principles of suturing, they make a difference. Do not debride stromal tissue. This I didn't mention. If there are multiple lacerations, like in the skin, you will cut out excess tissue. Never do that in the cornea. Put all of them back into place like a jigsaw puzzle. The moment you debride even a little sliver of the corneal stroma, the sutures have to be tightened too much to bring that together, and you end up with a lot of astigmatism. So that's important. Explore the extremities in the sclera, very important. Start suturing at the extremities and move centrally. Do not bury the knot in the wound. And remember, glue if you come unstuck. If there's a leak despite your sutures, and again, I think at that point it will be good to, and I'm not going to talk about corneal grafts here because we're talking only about lacerations, because the principles of corneal graft suturing are very similar to what I've mentioned. And at this point, I will stop, and then what we'll do is, whether we have time for questions now. We can take 2 or 3 questions if anybody wants to clarify any bit they haven't. We'll move on to a completely different topic, which is corneal gluing. So we won't defer questions till later. Anybody wants to ask anything, now is the time on suturing.
Any questions for Professor Dua?
No. Okay, let's move on to corneal gluing. And it's a pleasure to invite Dr. Said now.
There's one question here. There.
Right. Yeah.
You can use the microphone.
Sir, the length of the sutures should be same from periphery to the midway, or it should be different?
So the length is the vertical height, right? And at the periphery, they can be longer. So the longer they are, the fewer you have. You can put them further away. Therefore, the fewer you have to put. But as you move towards the center and towards the visual axis, you tend to make them smaller. So you have to make them closer to each other, because the distance between the smaller sutures will obviously be smaller.
Thank you, sir.
Yeah. Okay.
Yeah, I think.
Excuse me, sir. Can I have a question?
Sure. Okay. By the time.
What can we do in a zigzag tear, sir?
In a
zigzag tear. Zigzag tear, sir. Irregular
a
tear.
zigzag tear. Sorry. Yes. So you treat each component as to what it is. In a zigzag tear, it is you have anatomical points which you can approximate. You know, if it's an apex and a line and an apex and a line, it's like multiple short triangles. then you line the apex to apex and it falls into place. You will suture at the extremity, get the different apex points together. Alignment is very important, and when you can get the alignment right that way, then you can put in your other sutures. Yeah.
Yeah? Is it connected?
Dr. Dua, just a question. You mentioned somewhere in the beginning of the talk that the double arm sutures, the needle is better
Oh yes.
as
So
compared. Yeah, I think you forgot
yes,
to.
yes, sorry, yes, thank you for reminding me that. So it was all, I had covered that in my bit on the corners. So you have to bury the knots. When you've done your suture, you have to bury the knots. And if you're burying the knot, the width of the needle that comes with the double arm suture is a little wider than that comes with a single arm suture. So it's much easier to bury the knot if you have a slightly wider thing. And the other thing you will notice, which is something which is never been written in any book, I have never published it, but I've said it in all my talks for the last 5 years, is when you're trying to bury the knot, some knots go in very easily, some knots don't. And the reason for that is so simple that once you know the principle, it is easy to understand, is that if you're, I'll tell you what I'll do. Before my next talk, I'll show you the diagram, and I'll tell you how to make it very easy to bury the knots.